So my name is Andy Basenecker, and in addition to being a part of the Improved Medicare for All group, I'm also a director for annual giving for a nonprofit here in town. I work closely with donors and things like that from across the globe. The program's called Semester at Sea, and so we have the privilege of sending college students on a ship around the globe twice a year. Before COVID, that was much easier. We won't sail again until September of next year, most likely. So in the meantime, we're just doing all we can, like everybody else in our community, coping with COVID. I'm also a Lutheran clergy, which is where my intersection with Medicare for All really took a pointed turn, in that I count myself as really privileged to have spent time with family members and things like that throughout the course of the years. Both being in the emergency room as someone's being placed on a 48-hour mental health hold with that individual, or hospice care, holding the hands of dying loved ones. And I think what's been a common thread in a lot of those experiences has been the question of, how am I going to pay for this? Or how is my loved one going to pay for this? And dying isn't cheap, living isn't cheap, and seeking medical attention isn't cheap. And for so many folks, that creates a barrier to care. And throughout my time as clergy, I've thought just what a shame and what a tragedy, really, that folks are relegated to worrying about the cost of seeking medically necessary care, as opposed to caring for themselves or the loved ones for whom they really just want the best for. And what a shame that we are participating in a system that places those profits over care for people. And so, in part, I've been working with Rich and the Medicare for All group for a number of years now, and trying to raise awareness around this important issue, because these discussions happen in medical facilities across the country, certainly here in Colorado, each and every day, where people are forced to make difficult decisions about the care they do or don't seek based on the cost. And I am more convinced now than ever that healthcare is a human right and something that we need to work to ensure. So with that, during our time together, we're going to consider what it might be like to enjoy healthcare without the financial stress in this time of pandemic stress. We're also going to learn about legislation that could give you a taste of what Improved Medicare for All has to offer. And even if you know a lot about Medicare, our panel of presenters will shed some light on Medicare for All basics and some common myths you've probably heard, which are probably some of the points of pushback you might get if you share some of this information. And then we're hoping to help you become a more effective advocate for Improved Medicare for All, what to say and what not to say. So we're going to go over some basics next, and I am happy to hand it over to Emily.
All right, thank you, Andy. So as Andy mentioned, and I said earlier, my name's Emily Galashote. I've been to many salons. I am a research scientist here at CSU. So my background is in microbiology and immunology. So especially with the pandemic now, more than ever, like most of us, just understanding how important Medicare for All is. And I'm also part of the Fort Collins Democratic Socialists of America. So we'll be talking about some stuff with that at the end as well. So just to start talking about with the history of universal health care in the US, these are not new radical ideas. So this was first kind of proposed over 100 years ago in 1912, where it was proposed by Theodore Roosevelt. And then in 1935, universal health care was again championed by Franklin D. Roosevelt. In 1945, it was included in Harry Truman's Fair Deal. And it was finally in 1965 when President Johnson passed Medicare, so for individuals over 65 years of age, and Medicaid. So that was 55 years ago. And at the time, this was intended to be an incremental step to cover people of all ages. So the thought was, we'll start at over 65 and we'll slowly lower the age. And as we all know, it's still starting at 65 years of age now. In the 70s, people with permanent disabilities were added. In the 80s, hospice services were added. And then in 2003, legislation was added that would include filling in gaps in prescription drug coverage. But really nothing else has changed substantially since then. In 2003, the Improved and Expanded Medicare for All Act was introduced by John Conyers. So even this idea of Medicare for all has been around for 17 years. And then in 2010, the Affordable Care Act was passed. When we talk about universal health care, there's a ton of different plans that are being kind of thrown around under this greater umbrella of universal health care. So one of them is the idea that we can strengthen or fix the Affordable Care Act. Another being that we can just expand Medicare and Medicaid eligibility, so possibly decreasing that age so you buy in at 55. We can develop a public option. We can leave it to the states to come up with their own plan, which means 50 plans. And then the one that we're obviously going to be talking about the most today is single payer or Medicare for all. So the reason we pick Medicare for all are some of these drawbacks to the other plans. So buy-in programs really hardly reduces the number of uninsured individuals. So the Congressional Budget Office, the CBO, estimates even with a buy-in program, only 2 million more people will gain insurance, which means we still have 28 million individuals uninsured, and that's just unacceptable. A public option would only cover about half of an individual's total medical expenses, and it also doesn't guarantee a lot of things. It doesn't guarantee coverage for US residents. It doesn't cover all necessary care. It doesn't ensure choice of doctor, and it doesn't control costs, namely because it doesn't eliminate copays and deductibles. So a public option isn't great. If we preserve any aspect of private insurance, it perpetuates this problem of a fragmented multi-payer and for-profit system. And so with private insurance, profit-making reigns. That's the ultimate goal. And because of that, it is going to benefit shareholders and corporate heads. So the CEOs of insurance companies are incredibly wealthy. And that's because this profit-making benefits them over us, the patients and the providers. With private insurance, this multi-player system, you have redundant billing systems across all the different companies and plans, administrative claims, denials. It makes it incredibly wasteful. There's constantly changing rules and updates with pre-authorizations, facilities, networks, and it makes it incredibly complicated, as I think anyone with insurance has experienced. And it's also decentralized. So with all these different plans, we have no negotiating power for equipment, pharmaceuticals, drug prices, nothing like that. There's also Medicare Advantage, which you might have heard of, which takes public money and it hands it to a for-profit insurance company. So even though it has Medicare in the name, it is still a for-profit insurance company. So for Medicare for All, one of the big things we hear about is that it needs to be financially sustainable, which we're very aware of. And in order for that to happen, there's a couple things. So it's really important that there is a balance between young and healthy and old and sick individuals all covered under the same plan. So right now, insurance companies profit tremendously by covering young and healthy people. And if you have too many pre-existing conditions, you are too expensive to them and they don't want to cover you. And when we look at Medicare and Medicaid, they cover the most costly in our community, the old, the disabled, and the poor. And so having these all under the same plan makes it more financially sustainable. Going back to negotiating power, we all need to be covered under one plan. That way we have the power to negotiate. We greatly reduce administrative costs by everyone being on one single plan. So again, this idea of in-network versus out-network, are you platinum or gold? Do you get this claim or denial? It makes it incredibly administratively costly. And so we can eliminate that by all being under one plan. And then fundamentally important to us is that profiteering must be eliminated. Insurance companies, those CEOs make millions of dollars by denying us healthcare. And that's just morally and ethically wrong. So we believe all profiteering must be eliminated. So Medicare has had a lot of successes. It's passed the test. It's been around for 55 years now, and it has outperformed commercial insurance. Like I mentioned before, it has been the single payer for the group of Americans who have the greatest medical needs. Again, the elderly and the disabled. And compared to the insurance industry, it has higher customer satisfaction and is less costly. And it's not like, well, it's not providing as good of care, because it provides, same as some of the better insurance plans, the treatments that meet the professional standards of care. So it costs less, higher customer satisfaction, and it meets these high standards. And a lot of people celebrate reaching Medicare age because it means they know they will finally have quality healthcare, choice of provider. It's not going to be limited by in or out of network, and they will have healthcare as long as they live. And as someone who's not quite at that age yet, none of those things currently apply to me or my healthcare insurance options. So can't wait to be 65 or when we get Medicare for all. So Medicare is great, but what we really want is improved and expanded Medicare for all. It's had some great successes, but we acknowledge that Medicare is not perfect and there's a lot lacking from it. So when we talk about improved and expanded Medicare for all, we are adding all these benefits to the established Medicare system. So all these services that aren't currently covered, such as dental, vision, hearing, emergency care, these would all be covered under Improved Medicare for All. For Colorado, it also adds all of the more comprehensive Medicaid services that are offered in Colorado. And some of those include family planning, rehabilitation services, outpatient care. So this isn't just the Medicare you know it as it is today. It adds a ton onto it. It also adds some of the services of the popular Silver Sneaker health maintenance program, which includes stuff like physical activities and fitness stuff. It regulates the cost of drugs, devices, transport, and other services essential for life and health. It eliminates deductibles, coinsurance, and copays, so you don't need that supplemental or gap insurance, and you have full choice of provider. So in addition, we recognize that Medicare has underpaid some providers, primarily including those in primary care, mental health, and rural providers. And so with an improved and expanded Medicare for all, we would negotiate with healthcare providers from each specialty for fair and equitable compensation. We would also, in Improved Medicare for All, it includes a public health component, which I think 2020 has made more clear to us than ever before, that would help prepare for and protect us from pandemics, which I think as we're experiencing, we see just how vastly unprepared our current healthcare system is for providing that to us. So it really is that simple. So here's a cartoon. And if the stuff on the right you can't read, that's the insurance side. That's how it currently exists. So it should be complicated. On the left-hand side, it's individuals' medical expenses under a single payer. And the boy holding it says, "You're making this too hard, way too hard." And it really is that simple. We're all under one plan. All of the insurance companies and co-ops and subsidies are removed from the equation. So in between these sections, I'll go through some myths you might have heard. And so the first myth, and especially when we talk about elections, these topics get brought up more, but that the government will choose my providers. I don't want this Medicare for all because the government's going to choose. But in reality, as we just talked about, Improved Medicare for All creates more choice. It allows patients the freedom to choose providers, and it removes all network restrictions. So for any of you who've traveled within the US or you go from one state to the next, are you out of network? Can you see a doctor there? And then even locally in Fort Collins, at one place, there might be people in network or out of network. And so it just completely removes that. So you end up having far more choice under this program. So now that you know some basics about this, we're going to go on to Andy's section where we'll be envisioning life with improved Medicare for all.
Great. Well, thanks, Emily. I have an audio clip to share with you. And as we listen to this, you might want to think about some of the questions off to the right-hand side, which we'll be using as our discussion prompts for this next session. And I'll just read those quickly before we hear this section. The interview is between Michael Moore and Anand Giridharadas. It raises a bunch of interesting questions and points, but some of which we might discuss here would include: what would it mean for you and your family to not have to worry about healthcare bills? What resonates with you from the audio clip we're about to hear? And is what Anand shares, is that helpful? And you'll hear more about that. Should we be using the kind of messaging he suggests and engaging in this kind of dialogue? So we'll hear the clip, and then just a quick reminder, you have the ability to virtually raise your hand on the participant screen. And it's a button at the bottom of the center of your screen. If you click on the participants, then you'll see yourself and you can raise your hand. So if after we've heard the clip and we're starting our discussion, if you'd like to chime in, that's a great way to do it. You just click that button to raise your hand there. So here's the clip from Anand and Michael Moore.
I want to hear about freedom from illness as a vital American freedom. I want to hear about, like, I was saying the other day, and I was sort of as a joke, but also seriously, like, I think the Battle of Normandy should be invoked every time someone talks about healthcare. And I think someone should find a story of some dude who ran 8 times back and forth from the waterline to the cliffs to drag people he didn't know to safety, people he would never see again. And we should understand that as a metaphor for the kind of health system that soldiers deserve to come home to and everybody else deserves to have. I think we should undersell that as, like, this is who we are, right? We take care of each other. We have taken care of each other. This is who we are. This is patriotism. And we should flip on the first point. We should flip this dynamic where ruthless capitalism that leaves people on the street is American somehow, and is the policy of, like, hot dogs and apple pie, and actually having the back of your fellow Americans, even though you don't know their name, is somehow vaguely European. So that's number one. I think I want to hear way more patriotism.
It's patriotic to do that.
Yes.
Yeah.
And I want to hear, and I think what's funny on the left is because of the war thing and because of imperialism, like, there's this shyness around patriotism. And I think we on the left need to actually get over that a little bit on the right issues, right? I don't think we should go be fighting stupid wars because of patriotism. But I think there's a language, the language of justice isn't the only language to sell some of this stuff. So that's kind of point number one. Point number two is the, almost the opposite. Another very powerful American language, vernacular, is the language of personal transformation. Follow this diet, you'll change your life. Drink this shake, your marriage will be saved, right? Take this pill, your love life will be enhanced, right? We love that. You go to the grocery store, what did 9 out of 10 magazines right at the end, the ones that they're trying to hope you buy even though you didn't want to buy it, you don't have the budget for it. What are they trying to sell you? You can change, your life can change. Now, this whole American rhetoric of personal transformation is personal. It's normally like, you personally do this one thing and your life will be better. And it's all, the responsibility is all on the person. I'm sure they went to people in Flint and said, yeah, you lost your job, this and that, but if you, and I'm sure you can't eat healthy options now, but if you do this, you can change your life. What I want some of these progressives to learn to do is to co-opt this language of personal transformation, but for grand public policy. And to say, not what would you do, but who would you be? Who would you be? What kind of self would you have if you didn't have student debt? What kind of marriage would you have if healthcare anxiety was not a part of your marriage, right? What kind of relationship with your children would you have if you could work one job instead of three? And actually invite people, because a lot of this stuff in the progressive movement sounds a lot like the way I sound, frankly, a lot of time, which is like corruption is bad, this is bad, this is bad. I think we have to do better, myself included, of showing people what life will be like if this succeeds. What will your life be like? I think what no one says, what I don't hear Elizabeth Warren saying enough, Bernie Sanders saying enough, is like, life will be so much more fun in America if we win.
Right.
Like, let's not bury the lead here. Yes,
right.
yes. Transitions, phase it. Yes, sure, all of it.
Right.
You know what's really fun? To like not think about healthcare for the rest of your life and where it's going to come from. That is fun. It's a better, more fun life. Call your friends with that half an hour. You don't have to stare at a medical bill, right?
To have the money to take a vacation.
Correct.
To have the time off. To have any of the things that we should have as human beings.
Money, as we know, is a leading stressor that causes divorces, right?
Right.
How many things people go to therapy? People try, as an Indian person, I can say, people try tantra. People try all kinds of stuff to spice up your marriage. You know what will really spice up your marriage? Not having student debt or to pay for healthcare.
Right.
Right? And I think part of when I think about how do you not have the repeat of 2016 in places like Michigan, I want to see progressives going to places like that and unapologetically pushing for the policies we've been hearing, but talking about it in a language of patriotism and talking about it in a language of personal transformation and helping people see that this is the American thing, what we're pushing, and this is the thing that will make your life thrilling, fun, full of love, whole, and to not lose this argument to some of the most ruthless, greedy, mercenary people on earth.
So a lot of stuff in there, and I just shared a link to Anand's bio in the chat in case you're wanting to learn a little bit more about him. And as you're thinking about the questions you might have, I'll just share some real high-level overview of his work. He's got a book out most recently. It's called Winners Take All, The Elite Charade of Changing the World. And he's got a few other publications there. He's an editor-at-large for Time and an analyst for MSNBC, where you might have seen him before. Born in Cleveland, and then in Paris, France, and Maryland is where he has spent some time. Educated at the University of Michigan, which is the second best university in the state of Michigan behind Michigan State, but we won't hold that against him. And he lives in Brooklyn, New York at present. So quite an interesting guy. And so what did that raise up for you as you heard those clips? If you want to raise those hands on your, by clicking the participants and raising your hand there, what did you hear? What resonated with you from that clip? Yeah, I mean, he brought up three really amazing points there. I mean, the one of it that really resonated with me was it's not just justice language. There's a whole nother conversation to be had. And I thought it was really powerful when he talked about co-opting that message of personal transformation. The who would you be if you didn't have to sort through medical bills to try to decipher the mumbo jumbo that your insurance company sends you every month? I mean, that's incredibly powerful to think about. Who else heard something in there that either resonated with them, or did you think it was helpful the way he messaged some of these things? Okay, Jerry, would you mind chiming in?
Sorry. I just thought it was really interesting. Again, what kind of person would you be if you didn't have to worry about this? And I know we've talked about this in other settings, but let's say you didn't have to worry about losing your health care if you changed employers. Would your life be happier if you could go to another job that you would prefer to do and still have your health care? I mean, there's just all kinds of possibilities of things that having, not to worry about health care could do to a person's life. So yeah, I think it's awesome what he said.
I mean, I think, and I'll raise my hand as somebody who knows people who continue to make decisions based on their employment and its relation to their health insurance, right? Either not retiring or choosing to stay at a job you don't like. I mean, those stories are not uncommon. Elaine, I see you've got your hand raised there.
Yes, is the point that he made about not having to even think about health care reminds me of one of our cohorts. Aaron is from Australia, and he often has made that point, is that when he was growing up, I mean, it wasn't an issue. You know, if they were sick, they went to the doctor, and it wasn't a huge concern. So I think that's a real important point.
And Jim, I see you've got your hand raised as well, Jim Potter.
Yeah, I think one really important thing is that you don't have to worry about healthcare bills, and you don't have to worry about being unemployed if your medical care is not tied to employment. And one thing that we have discovered as a result of this pandemic is that employer-provided health insurance is of no use to you if you lose your job. All of a sudden, you're out in the cold, you're uninsured, and you have no recourse. And with Medicare for All, you would be covered. It's not tied to employment, so you have greater freedom of movement and greater freedom to engage in other occupations or even to be unemployed for a certain period of time.
Yeah, I mean, talk about doubling down on the risk that this pandemic presents to folks if you find yourself out of work and suddenly uninsured as a result. I mean, people are just placed in this precarious situation, even more so because their insurance is tied to their employment, and that's a incredible tragedy, especially now. Other thoughts or questions, or is this the kind of messaging you think that would be helpful? I mean, it is a incredibly important time of year, I guess, with the election coming up, and of course, lots of decisions and things like that. Is this messaging helpful, you think, for folks? I mean, Michael Moore is obviously in Michigan, and certainly that's an important place to consider. But what do you all think? Should we be using the messaging that Anand suggests here? I mean, it's powerful, right? And when you hear Anand lay it out in less than 5 minutes.
Yes.
Why don't we move on now? I'm going to hand things over here to Emily again for a Mythbuster.
Yes. So this one isn't as much of a myth, but maybe more of a sentiment you've heard, that I don't trust the government to take over my healthcare. And I think depending on who your circle is, they might have different levels of trust in the government on any given day. But that's something that we might be hearing, or you might have heard. When we think about it, who do you trust more to know what is best for you and to make decisions about your healthcare? A profit-driven corporation, which is what we currently have for those of us not lucky enough to be on Medicare, or you and your doctor? And so the thought that a Medicare for All system is going to give the power to the government, it's really taking it away from the current insurance companies and returning it to you and your doctor to make those decisions. Current Medicare is by the government, and do we trust our Medicare program? I think it doesn't deny coverage for necessary care or pre-existing conditions. So Improved Medicare for All is really just an expansion of a system that's already working. And it's not the government deciding what medical care you do or don't get. And back in 2009, which feels like forever ago these days, Newt Gingrich had argued that if we were to do this, the government will become death panels determining who lives and dies. And that death panel phrase kind of really took hold. But in reality, today, it's insurance companies that are those death panels. And they ration care by denying coverage. And so it results in people dying every day already. And so we really can't afford to not fight for this, because people and our peers, my peers, are suffering and dying. So the government isn't going to take it over. It will return the power to you as the patient and your provider to determine your care. So up next, Julie is going to talk about the Healthcare Emergency Guarantee Act, which will talk a lot about our current situation and some ways, some action we can take.
Hi, I'm Julie Rowan-Zock, and I'm a local bookseller at Old Firehouse Books and an author, illustrator of children's books myself. I'm going to be reading a summary of the Healthcare Emergency Guarantee Act, which was proposed by Bernie Sanders and Pramila Jayapal, which can be found online, but we'll also be posting a link for you for further reference. So, while it's not Medicare for all, it can be a stepping stone towards it. Our nation is facing a catastrophic health crisis that Congress must address. Even before coronavirus pandemic, 87 million Americans were uninsured or underinsured. That number is rapidly escalating as millions of workers are not only losing their jobs, but also losing their employer-based health insurance as well. In fact, it's been estimated that as many as 35 million Americans will lose their employer-provided health insurance during the coronavirus pandemic, and about 11 million Americans could soon enter the ranks of the uninsured. The cost of hospital treatment for the coronavirus amounts to tens of thousands of dollars. Tragically, we have already seen people who have delayed treatment due to concerns about the cost. In this pandemic, lack of insurance will lead to more deaths and more COVID-19 transmissions. During this unprecedented crisis, no one in America should delay seeking medical care because of the cost. We cannot live in a nation where if you're rich, you get all the treatment that you need, but if you're poor or a working class family, you are out of luck. The Healthcare Emergency Guarantee Act would empower the government to leverage the existing efficiency of Medicare's payment infrastructure to ensure COVID-19 relief funding goes directly to patient care without changing families' insurance coverage or touching the Medicare Trust Fund. Under the bill, the federal government would pay all of the costs of treatment for the uninsured and all of the out-of-pocket costs for those with public or private insurance for as long as this pandemic continues. No one in America who is sick, regardless of income or immigration status, should be afraid to seek the medical treatment they need during this national crisis. So could you change the slide? Thank you. Okay, so under this legislation, Medicare will cover patient costs during the COVID-19 crisis. For insured Americans, Medicare will improve the coverage of individuals who already have public or private insurance by paying the copays, deductibles, or other out-of-pocket expenses for all medically necessary health care, including prescription drugs. The Healthcare Emergency Guarantee Act defines applicable health care items and services as any healthcare items and services that are medically necessary or appropriate for the maintenance of health or for the diagnosis, treatment, or rehabilitation of a health condition, including but not limited to COVID-19 testing and treatment. For uninsured Americans, Medicare will fully cover the cost of medically necessary health care, including prescription drugs, for individuals who are uninsured. Those who become insured during the crisis will have out-of-pocket expenses covered. The effective date. Both of these provisions will last from now until the Secretary of Human Health and Services certifies that an FDA-approved COVID-19 vaccination is widely available to the public. How it works. When individuals go to the hospital or doctor, they will provide their insurance information as usual. The provider will use this information to bill Medicare, either for the out-of-pocket costs, if the individual has another type of insurance, or for all of the care if the individual is uninsured. The patient will not be charged anything. Switch the slide, please. So additional provisions. No surprise billing or balance billing. Providers cannot bill patients, and any qualified licensed provider is eligible to be reimbursed for providing medically necessary care. Participating providers must immediately halt medical debt collection during the crisis. So limit prescription drug prices. The federal government will pay the same price as the VA for prescription drugs that are provided to the individuals who are uninsured. Private insurance companies cannot decrease coverage. Private insurers cannot increase co-payments and deductibles or decrease coverage just because the federal government is picking up the bill. Waive late enrollment penalty for the Medicare program. Today, seniors may be forced to pay a higher premium if they do not enroll in Medicare right when they turn 65, and this would be waived during the public health emergency so that seniors who want to enroll in Medicare can do so quickly. Any out-of-pocket expenses would then be covered through the new funding mechanism created by this act. Oversight on implementation. Reporting on COVID-19 health disparities. This would require weekly, publicly available reports to Congress on implementation and the distribution of funds. Requires the Secretary of Health and Human Services to collect and report data on COVID-19 health disparities across race, ethnicity, primary language, gender, sexual orientation, disability status, age, geographic area, insurance status, and socioeconomic status. We can't beat this pandemic if millions can't afford to seek out care when they feel sick. So I'm going to hand this back off to Emily for another Mythbuster, or are we going right to discussion? I guess to discussion?
Discussion on this. So again, focusing on this aspect, and then we'll have the general Q&A at the end.
Okay, so if anybody wants to virtually raise their hand, I appreciate some help from Andy, if it's possible to click on the participants.
Yeah, of course. And, you know, I was wondering too, we are privileged to have Dr. Kathy Egan with us. And Kathy, I don't mean to put you on the spot, but do you have any reactions to this legislation? I was just kind of wondering, as a family physician, what your thoughts were on this.
Yeah, I mean, you know, I think it would be amazing. Yeah, I mean, it's my patients that have been hospitalized with COVID are all Hispanic from the Loveland Community Health Center. And most of them have no insurance. So I don't know how they're going to pay their bills. And yeah, this COVID has just absolutely shown, you know, has just hit hardest those with the least, people of color, and not those of us who have good health insurance, good jobs, and can work from home, etc. So it really would be amazing. I guess the skeptical part of me is just wondering how in debt Congress is going to let us get. But yeah, thank you. In terms of, you know, reducing human misery, and this would be a really, really amazing and important thing to do.
Well, I know sarcasm doesn't often translate virtually, but we are all aware of just how efficient and ready the Senate is to take up any legislation which would help the American people. So I'm sure results are just coming as we speak. And Emily, sorry.
Yeah, so I can speak to this and the thought about family members, friends, and neighbors. So I have a lot of peers here in Fort Collins. As we know, it's a college town, and a lot of people work in the service industry. I mean, that's a huge part. We are blessed to have so many restaurants and breweries and coffee shops. But when this hit, all those places shut down, and my community members and my neighbors lost their job. And on top of hardly making enough money to survive here, having COVID on top of it and losing the little health insurance they were lucky enough to have. So I think obviously this impacts everyone everywhere, but especially in a college town like Fort Collins, you look at who's serving you and who's a lot of people and are struggling because of this. So definitely resonates with that, with, our community right here.
So if you have comments or questions or about the Healthcare Emergency Guarantee Act, please feel free to raise your hand. We're happy to call on you. I'm just scrolling through the list here for you, Julie, to see if there's anybody. Let's see. I thought I saw somebody for a moment.
Lene?
Oh, Jim Potter. Jim, do you want to chime in?
Sure. One thing about federal deficits and all of that is that it's never a consideration when it comes to giving tax breaks to corporations or increasing the military budget or doing any number of other things to benefit the wealthy in this country. So I think one problem that a lot of people have with Improved Medicare for All or with the Healthcare Emergency Guarantee Act is that it will cost a lot of money. But in fact, it's going to save a lot of money because more people will have access to healthcare and they will get treated early before they have to go to emergency rooms. The other thing is that in the HEROES Act that was passed by the House back in May, it provides for a COBRA extension for all people who have lost their employer-provided health insurance. But the problem with the COBRA extension is that it doesn't cover the 29 million uninsured, and it's a big boon for the health insurance companies. Here we are with a crisis of people being unemployed who now can't afford to pay the deductibles and copays that would be provided by this COBRA extension. So they're not going to access health care. And the result is going to be that the private health insurance companies will make even more money during this crisis than they would have otherwise. But the other thing is that the Healthcare Emergency Guarantee Act is actually going to cost $72 billion less than the COBRA extension in the HEROES Act. So in many ways, it's a bargain.
Absolutely.
Thanks, Jim. That's really good information to hear. And it's been said before, but budgets are moral documents. If you show me where you're spending your money, I'll show you what you value, right? Let's see, Elaine, it looks like you've got your hand raised.
Yes, I am thinking that this could be a real turning point. And looking at folks that are reacting as far as Black Lives Matter, or people that are willing to go on employment strikes. I think that this is a time that we can all unite together and make a fuss. Making a fuss seems to make a difference, and especially to our elected officials. So
this is good trouble to get in, right? Great, thanks. Well,
So
I'm not seeing any other hands. Oh, Kelly.
This is Sally.
Sally.
I noticed in one of the slides, and we didn't really touch on it, it talked about hospitals going under. And I know that that's a huge issue in rural areas. And I know people who have to travel, 100 miles to get care. And if you are dealing with COVID symptoms, you're not going to want to travel 100 miles to get any kind of care. I'm wondering if somebody on the panel can address that issue a little bit more, how this looks at that.
I'd be glad to give a response.
Thanks, Rich.
Maybe pick this up under Q&A, but under Improved Medicare for All, and not and potentially under the Healthcare Emergency Guarantee Act, just as Andy was saying a minute ago, put your money where your mouth is. If you want hospitals in rural America, then pay the doctors that are willing to and want to work in rural America an incentive to be there. This is not rocket science. Also, in rural America, you have a huge percentage of the population that's on Medicaid, the program for low-income residents, which means the hospitals and doctors are not getting reimbursed for their cost of service. It's constantly struggling to even break even. So potentially the Healthcare Emergency Guarantee Act provides temporary relief for the rural hospitals because they now start actually getting paid better than they would be otherwise, because another percentage of their patients are those who have no insurance. And certainly under Improved Medicare for All, that whole rural hospital issue gets addressed head on.
Great. Well, thank you, Rich. Let's see here.
I'd say one more thing too. I can't raise my hand either.
Yeah.
Hi, I just wanted to point out, because my daughter lives in Germany where they do have not exactly a single payer system, but where she gets all her healthcare covered, that the crisis didn't make any difference for the healthcare coverage in a country like that. There was no new plan needed. There was no new things that needed to be discussed in Congress or come up with amongst doctors, because that's the way they operate. So that would, considering the fact that climate change is going to be bringing more pandemics for sure, we know that already, that looks towards the future. So Medicare for All is not only going to possibly help us through a crisis like now with the Healthcare Emergency Care Act or Guarantee Act, but think of the time we'd save. Think of the lesser amount of transmissions just because people are getting care when they need it. So thank you.
Great. Well, I'm thinking we might want to move along to our next section here, which I think is segued by a Mythbuster by Emily.
Yes. So another myth, and one that comes up a lot, and we'll probably have some more Q&A about this at the end, but single payer is politically unfeasible. So I know I've heard that a ton. And in reality, the fact and the numbers are really winning over myth. So it's important to acknowledge that those profiting from the current system aren't going down without a fight, and they have a ton of money, partially because it's an industry that makes money. But the stigma around single payer has really dropped over the years, and broad majorities across party affiliation are supporting the idea of universal health care and the idea that all Americans having access to affordable health care. And especially within this last 6 months or so, in some of the earlier Democratic debates where some of those candidates were really supporting this, it just became so much more pertinent in the news, and we've been hearing a lot more about it. And as has come up in the chat some, more Americans are seeing how they will benefit from a program like Medicare for All. And the change is possible if we demand it, or if we make a fuss, like Elaine said, which I particularly like. So we're gonna hand it over to Rich, who's going to talk to us about messaging and how to be an effective Improved Medicare for All advocate.
Again, Rich Shannon, Fort Collins resident and longtime member of the Colorado Foundation for Universal Healthcare, and delighted to be here in my first salon. And Emily, will you be advancing slides when I need them? Thank you. So the last section here is on messaging, and everyone who's part of this salon is a fully skilled participant in the political process, or you wouldn't be here. You know how important it is, how important messaging is, how important it is to frame a public policy issue in a way the audience can understand it. That's incredibly important in the Improved Medicare for All movement. So if you remember nothing else from my portion of this presentation, please remember these 2 points: that the audience is the 20 to 25% in the middle, and the conversation needs to be through understanding and using shared value language. And I'll get back to that. but this 20 to 25% in the middle. Poll after poll shows a pretty strong support for Medicare for all, easily 50%. We also know that 25 to 30% will never get there. That's just the nature of major social change. So our audience, when we talk about Medicare for all, really needs to be using messaging and language that resonates with the 20 to 25% in the middle. And a lot of these folks are moderate conservatives. We need their help to really get that final push. Emily, you can advance it then. So this idea of shared values, terminology and framing that works for both liberals and conservatives. Some of you may already know this book, but it's a great starting point, and not just for Medicare for all, but for any political issue you're engaged with. Don't Think of an Elephant by George Lakoff. And if you get it, be sure you get the 2014 edition. Now, Lakoff has been studying this topic of how do conservatives think and talk and how do liberals think and talk for decades. He teaches at UC Berkeley. He's also taught at Harvard and at Stanford. And his research, not surprisingly, shows that liberals and conservatives are literally wired differently. Their brains react differently. And his conclusion is that that difference all comes down to one key element. It's how you personally define morality and moral behavior. And out of that, everything else emerges. Your reaction to a whole host of political issues is based on how you frame moral behavior. One more, Emily. So in 2012, Bill Moyers was interviewing Jonathan Haidt, who you see here is the author of a book called The Righteous Mind. And this is long before a lot of the Improved Medicare for All movement was taking place. So this interview was just, again, the same thing that Lakoff was talking about. And here's Haidt's conclusion, that there are 6 overlapping values that we can work with when we're trying to talk with conservatives, moderate conservatives, a big part of that 20% we're trying to connect with. So you see the 6 values here: care, liberty, fairness, loyalty, authority, and sanctity. I had to look up sanctity, being the quality of being holy, sacred, or saintly. Now what Haidt says is that liberals really like those first 3, care, liberty, and fairness, a lot. Loyalty, authority, and sanctity, a little bit. It's okay, but not high on the list. But interestingly, conservatives value all 6 of these at about the same level. So what that means is when we're talking about fairness and individual freedom for people, conservatives can relate to that. But our goal as liberals is to relate to them better, which means how can we talk about improved Medicare for all in terms around loyalty, authority, or sanctity? And we'll see some of that here in a minute. For example, loyalty, we heard already in the interview with Michael Moore. Patriotism is a big part of loyalty. Could also be in sanctity. So while this whole movement of better messaging for Medicare for all is a work in progress, we can start to see what that might look like. And the challenge for all of us is start experimenting with it, start to use it. That we are our own worst enemies when we talk about Medicare for all, when all we do is scream loud liberal phrases that our far left liberal friends love to hear. It's not helping the cause. Emily, once more, please. So this is from Dr. Ed Weisbart. Now, more recently, or he is a more recent student of this. He's a doctor and a member of Physicians for National Health Program. He's been studying the subject for a couple of years. He admits to listening to Rush Limbaugh for 15 minutes a day for about 6 months because he really wanted to understand how Limbaugh can be so good at keeping his audience spellbound. What kind of words does he use? What phrase? How does he frame the issues? And this is a summary slide from a webinar he gave a little while back, what he calls nonpartisan messages for Medicare for all. Simple, prudent, and proudly American. It's simple, it's not complicated, which certainly gets to the issue of fairness. But this next one's interesting. Stop wasting our money. It's easy for us to talk about how all the savings we're going to have. But his research says people have a much stronger emotional attachment to losing something than they do have an emotional attachment about potentially gaining something, like gaining the savings. So he always talks in terms of let's stop wasting our money. No one should take away your choice of doctor. We've heard that a lot already tonight. This freedom aspect should be you and your doctor. You're losing something if you have to work in a network. Businesses should focus on their business. Once again, Medicare is proudly American. We're really proud of that and what it's done for seniors. Now you'll notice one thing that's not there and that Ed Weisbart emphasized in his speech. He never uses the phrase, healthcare is a human right. And most of us are used to repeating it regularly. So I find myself having to bite my tongue when I want to say that. Here's what Dr. Weisbart says. Really, healthcare is a human right? Where does it say that? Is it in the Constitution? Is it in the Bible? His point is that a phrase like that triggers entitlement mentality on the part of a conservative hearing you use that kind of terminology. It's just another example of entitlement mentality. He's equally very selective when he uses phrases that sort of conjure up this, well, we're all in this together. Let's take care of each other. For a conservative, that can easily be interpreted as, oh, you want me to pay for those people. So we've got to work on changing. It's not about everyone should have. It's about you and your family. Weisbart said when he listened to Rush Limbaugh, there was a lot of discussion about you, and the pronouns that were used were key. So Weisbart talks about how important it is for you and your family, perhaps for the kids, the families next door that your kids play with. So this is important for you that this takes place. And you should only have to pay your fair share. Loyalty and patriotism, another example out of Weisbart's presentation. Because loyalty and patriotism are so big on the conservative scale, acknowledge them. And we can do this legitimately. His example is we have some great doctors and hospitals in the United States, and certainly in Northern Colorado, we can say that as well. We have some great doctors and hospitals, but overall the system is failing. America should have the best healthcare system in the world. We don't, and we need to fix that. We should be number one in healthcare, just like we're number one in so many other areas. So come back to loyalty, come back to patriotism. So Emily's going to show, put on a 1-minute video of an attempt at messaging that a Medicare for All group out of Ohio has put together. And Emily, did you?
Universal, simple, affordable. These are not the words anyone would use to describe American healthcare today. This election year, we will hear lots of talk about what's wrong in America and how to fix it. We believe that healthcare discussions should be framed using these 3 core concepts: universal, simple, affordable. If we don't agree on these core concepts, we will never agree on the details of reshaping healthcare. The fact is that right now, healthcare is neither universal or simple nor affordable, so it fails to provide needed care, and it creates physical and financial suffering for millions of Americans. In a year in which our nation is trying to find better approaches to achieve liberty and justice for all, these 3 words, universal, simple, and affordable, describe a vision that also strives to assure healthcare and well-being for all. How we talk about healthcare this year can lead to giant steps forward next year. This is what we want. This is what we need. This is what we all deserve. Universal, simple, and affordable care. USA Healthcare.
Okay. So lastly, we're going to see how the opposition does this messaging. And some of you may have heard the name Wendell Potter. Wendell, for years, was senior vice president, executive vice president at Cigna Health Insurance for corporate communications. He did a lot of the spin work, messaging for the insurance industry. And then one day he woke up after an event he had been at and said, I can't do this anymore. I can't look myself in the eyes and still send out this garbage. And he wrote a book called Deadly Spin, in essence, a whistleblower's description of what happens inside a health insurance company. And he's now one of the best national speakers for Medicare for All. And in this next video, he's dissecting a message that came out a few months ago from the opposition. And it's here partly for humor and partly just to see how this messaging is done. So.
Some of y'all might remember that back in the summer, big pharma, insurance companies, and private hospitals formed a nonprofit to protect their profits called the Partnership for America's Healthcare Future. Well, we've finally seen their first product, a 2.5-minute ad they're putting 5 figures behind to distribute online over the next 3 weeks. It's almost impressive how many lies they're able to fit into such a short clip. Let's run through a few.
Today, nearly 180 million Americans with employer-provided coverage have access to affordable, quality health care.
Starting off strong. It's true that 180 million Americans get health insurance from their employer, just under half the country. But employee contributions to their plans have gone up an average of 21% over the past 5 years, far outstripping average wage growth. So I wouldn't call it affordable. Secondly, it's not clear that the quality is so great. If you look at comparable wealthy countries, we have a lower life expectancy, higher rates of infant mortality, the highest rates of hospitalization for preventable diseases, and the highest rates of preventable death from medical conditions.
Most people get their care from employee-sponsored plans.
This is a little thing, but 49% is not most people.
Some people are proposing we start over and eliminate employer-provided insurance.
Technically, we're proposing we eliminate all commercial insurance, but I like where this is going.
Whether it's called Medicare for all,
Great.
single payer,
Now you're getting it.
or a public option.
2 out of 3 ain't bad, but pretending that the public option is the same as Medicare for all is a particularly devious lie. A public option would leave the commercial insurance industry in place and let them cherry pick the most profitable patients while putting less healthy, higher risk patients onto government programs. It'd be an improvement over what we have now, but wouldn't get us the needed cost savings built into single payer.
A one-size-fits-all healthcare system will mean all Americans have less choice and control over their doctors, treatments, and coverage.
This is just a bald-faced lie. Right now, if you have the luxury to be able to afford to visit the doctor, you can only go to physicians that are in-network and receive treatments that your insurance company approves. Under Medicare for All, you'd have the ability to go to any doctor or medical provider of your choosing, and we'd eliminate the profit incentive that insurance companies have to deny treatment.
It will also mean trillions in higher taxes for hardworking families, lower quality of care, and longer wait times for patients.
We already covered how our quality of care is actually much worse than what patients receive in single-payer countries. But let's cover the tax issue. It's true that there would be some new taxes for businesses and individuals to fund this Medicare for All system. However, they conveniently ignore the fact that a single-payer system would save us trillions of dollars over the next decade, and that as a result, the vast majority of workers and employers would be paying significantly less than they currently pay in premiums and out-of-pocket costs. Finally, we get to the industry's favorite talking point, wait times. There's no evidence that Medicare for All would lead to longer wait times for patients, but the reality is that currently, very few people in the U.S. receive the preventative care and screenings they need, and they ignore the fact that Americans wait longer than people anywhere else in the developed world to see a doctor for needed medical care due to cost, including people with private insurance with such high deductibles they can't afford to actually use it.
And healthcare decisions would be shifted from patients and their doctors to politicians and bureaucrats.
Right now, when your doctor decides that you need medical attention, you have to hope that your insurance company will decide to pay for it. Since the insurance company's only responsibility is to their shareholders, they will look for any way they can to ignore your doctor and deny the claim. If we take the profit motive away from healthcare financing, doctors will be able to provide the treatment they know you need, and you won't have to worry about drowning in medical debt. Seems like a no-brainer.
America could work to improve what's working.
It is absolutely not working. It's the most expensive system in the world. Nearly 28 million people are uninsured, and we have worse healthcare results.
This is just the start of our conversation.
Oh, so excited that we're all going to be subjected to more of these.
Thanks, Emily. All right. Looking at clock, I'd like to get to the call to actions. Emily, if we could see the first line. Julie mentioned in the discussion about the Healthcare Emergency Guarantee Act that we do have a call to action tonight, if you're so inclined. And it's to get the Fort Collins City Council to join a national movement called Medicare for All Resolutions. It's an attempt to get local governments across the country to express their opinion about what's needed. Some local elected officials will say, well, this is really a national issue. And our response is, yes, the solution is ultimately national, but the pain is very local. Right now, it's your constituents that are in pain, and we need to hear from you. This national movement is led by Public Citizen. It has 22 partner organizations, including, as you can see, National Nurses United, who does a great job of organizing. Physicians for a National Health Program is a great resource for information about what's not working. And Democratic Socialists of America are also very good at organizing and putting together some really good communication materials. So far, there are 41 cities and counties that have passed resolutions, and you can see a short list of some of those that have been approved already. Now, if you choose, and I hope you do, choose to call the mayor and city council members you know, start by giving them credit. Last year, well, first, many of you may know, but not everybody, that every year the Fort Collins City Council adopts something called a legislative policy agenda. Last year, and this legislative policy agenda is a document that currently covers 27 public policy issues, and each one has a short blurb, 2 to 3 paragraphs that captures basically the council's position and preferences. For the very first time last year, we got the council to include language about healthcare in the legislative policy agenda, and it's really pretty good. So when you call them, give them credit, acknowledge that they've tried to address this a little bit. Their policy calls for endorsing single-payer, not-for-profit healthcare, getting employers out of the role of providing health insurance, and funding a national healthcare system by people paying into it based on their ability to pay. Really good start. But they weren't ready last year to actually pass a resolution that adopts Medicare or endorses Medicare for all. So Emily, next slide. So when you call, recognize what has been done, but then let them know things, it's really important now that they take the next step and pass this resolution. Some of the early cities adopted a resolution that was specific to endorsing improved Medicare for all. But things have changed. The realities of the pandemic and the Black Lives Matter movement, which has shown just how much institutional racism is built into our healthcare system, really make this a reason for the city council to come to the forefront again. The new version of the resolution, the essence of it, each city modifies it a little bit, but the essence of it now includes this support for the Healthcare Emergency Guarantee Act, that we're in the middle of a pandemic, and as Julie's section pointed out, people are losing their jobs, they're losing their health insurance. We need the Healthcare Emergency Guarantee Act in place. And secondly, we need that as viewed as a stepping stone to improve Medicare for all. So that's the call to action. We hope you'll be so inclined. I know I've been in touch with my council member and hoping to hear back shortly as to whether she can recruit enough votes to get this on the agenda. So thank you for considering the call to action. We've got one more myth buster and then a little time for additional question, answer, and comments.
Yeah. So our last myth, and some of these came up throughout the videos we watched and the discussions, is doctors will never buy into improved Medicare for all because it will interfere with their autonomy and decrease their salaries. In reality, over 60% of physicians already support a single payer system. Talking about autonomy, some nurses, their full-time job is helping get authorizations so patients can get the care they need. So they're spending their time dealing with insurance companies instead of providing care. The network restrictions, pre-authorizations, denials, and second guessing by insurance companies of clinical recommendations restricts physicians' ability to practice medicine. So like we had talked about, your doctor might prescribe something and they have to hope that the people in the insurance company agree with their medical decision. When we talk about income, the average physician income should change little, although that income disparity between specialties is likely to shrink. So we talked about primary care, rural doctors, some of that. And so some of those salaries would be likely to increase, which could incentivize people to stay in those types of specialties or in those types of care. And some specialty care might decrease, but it will really decrease that income disparity and make it all more equitable and ultimately be better for providers and for patients. So with that,
Emily,
yep.
If I can add one thing to that, if you have friends that are doctors and are nervous, and it's usually the surgeons or the specialists that are a little nervous, yes, the negotiated price for their services may come down, but as Emily has pointed out, their costs to run their medical center, their medical office are going to come down enormously. The amount of support staff they have to hire to keep up with the bureaucracy today is enormous. So their net income is likely to change not very much, even though what they get paid for procedure may come down.
Plus they as individuals won't have to be paying copays and all of that, so they'll be better off anyway too. So with that, we now have a general Q&A, and I just wanted to comment because it's been in the chat. We will be saving all of the links that everyone's been sharing and these slides and a ton of resources. So we can provide these slides to everyone. So no need to frantically take notes or screenshots because we will be giving it to all of you. So,
Andrew, if it's okay, the first question that was entered early on is who would be the top administrators?
That's great. Yeah, Lene had that question very early on. Do you mind addressing that, Rich?
Sure. I think we can give a partial answer right now. When we talk about improved Medicare for all, it's not starting over. We have the infrastructure in place. We have the methodology, how those senior folks are appointed. The top people are appointed by the president. And today we can say we cringe a little bit about that. But the system's in place, and for 55 years in the Medicare, it has worked. And yes, there's some obvious political overlap there, but it's incredible to see how Medicare for All works. If I can give you just a couple of little statistics. The Director for Medicare and Medicare Services is Seema Verna. She gets paid $165,000 a year. Now there are just a couple of doctors working for her that get paid a little more, $252,000. Medicare covers 60 million people. And it does it with about 6,000 employees. Now let's look at the largest for-profit insurance company, United Healthcare. CEO David Wichmann got paid $18.9 million in total compensation in 2019. Some years it's been as high as 30 million with higher stock options. They cover 49 million people, much less than the 60 million by Medicare. And they do this with 325,000 employees compared to Medicare's 6,000. So the point is we have an existing infrastructure in place that is really very efficient and functioning.
I think that really dovetails with a comment that Rick left in the chat, which was that it really resonated with him, and I think it would resonate with our fellow citizens, how much money is actually wasted through a system of duplicative record keeping, repeated overhead to receive, to deliver the same results to a different population of people, and that it's just extremely wasteful. And that's interesting when you think about that, Rich, in terms of your messaging as well. I want to acknowledge as well a question Linda Blake asked early on. And then Gail, Marie, and Bill, I pulled this out of the chat as well, and I think this is a similar question. Linda just asked, you know, I think the biggest question that bears asking anytime we have this discussion, which is how do you do it? And then Gail, Marie, and Bill, I think your comment and question sort of dovetails on that, isn't that how have other nations made this shift? Certainly the United States is unique for a lot of terrible reasons in terms of our healthcare system, but I wonder if there's some panelists who want to speak about that a little bit. Like, and Rich, I think you got to it somewhat in your messaging, like some of the how do we do this? But I didn't know if you had more thoughts on that question from Linda.
Well, I don't think there's a 20 steps to get there. I think what we do is we look back on the history of social change and say, we as a country have done this before. We have made major change in the face of enormous opposition. And the people, again, are a part of this salon. You know the list. Women's right to vote, the civil rights movement, the creation of Medicare in the first place that was fought enormously by the medical community and the pharmaceutical community and the US Chamber of Commerce. Same participants today fighting it fought Medicare. The end of the war in Vietnam, gay rights. We've been through major social change before, and it always looks impossible until it happens. And you're probably all aware of Nelson Mandela's famous quote, "It's always impossible until it's done." And I think that's where we are today.
Great, and Linda did chime in the chat as well that she absolutely can imagine a world where Improved Medicare for All is a reality, and it's called Europe. And certainly, certainly I appreciate that. Okay, so let's see, if you have a question and you'd like to raise your hand, we're certainly, or just even a comment about what you've heard tonight, certainly open to hearing some of those reactions.
Well, so when Medicare was first introduced, the thought was we'll start at 65 and slowly reduce the age and do that. And I can speak to as when Bernie was running, that was a big way we would do it. We would start by kind of decreasing the age from the top and increasing it this way until slowly we meet in the middle. Yeah, I don't have anything more to add to that if anyone else does.
I wonder too if it's just not palatable for some of the messaging reasons that Rich mentioned. Like maybe the sticking point for some folks isn't lowering that age, but just the way we're framing the issue in the first place, that it's running across the grain of values systems that look at this issue very differently. And that's conjecture more than it is based in science, but it's just a thought that how we talk about it maybe is equally as important.
Yeah. The political reality, maybe that's what we try, especially if it's under a Biden administration, which, as you know, is one of his offers, is to lower it to age 60. It's another example of an incremental thought process that really fails to get to the heart of the issue. I think it was in Emily's comment where as long as a for-profit insurance industry is active and driving the legislation, writing it in most cases, you just don't get where you need to get to. So procedurally, it sounds, well, let's just go from 65 to 55. That does nothing to substantially reduce the cost. Cost is driven by complexity and by greed. If you don't get rid of complexity, it's very expensive to manage complexity. It's expensive emotionally to manage complexity, just as we heard from Michael Moore. But the other part is there an assumption here that it's the people between 65 and 55 who are most in need of healthcare and don't have it? They may actually be the ones that have still got that employer-sponsored plan that's not great, but it's providing something for them. What about the tens of millions that are uninsured that might be 35 or 45? We haven't gotten to the heart of the suffering either. If we take an incremental step, just because it sort of sounds like it has a nice manageable framing to it.
Yeah, it's hard to pat yourself on the back when you're still leaving so many people behind. Elaine, it looks like you've got your hand raised there. Maybe you're with us?
There
you are.
Yeah, I am. One thing is kind of like climate change. What we're doing is not sustainable. And so if we just do a little bit at a time, I mean, it's going to still be unsustainable. And so we just need, the big thing I think is we need to decide that that's what we're going to do, and then we'll do it. I always like to look back when Medicare was first implemented, is starting from essentially no real big insurance plan, is Medicare was fully implemented in less than 11 months without computers. So, we send a man to the moon. This is not, it has to do with intention. And so we need to just have that intention and then do it.
Great. And Sally asked a question, if there would be any limit to the cost of care to a person. We seem to know that some doctors will add test after test, or in an effort to beat death, will go to extremes in operations and procedures. Is there an incentive for doctors to provide preventative care? And I think we've heard this question before in some of our discussions about, like, do you think it incentivizes doctors to do those things, or people to seek out services that perhaps they don't need? I think Aaron had a really good response to this, but I don't know if anybody else on the panel wants to speak to that.
Emily, do you want to?
Well, I will just throw it back of how many of you enjoy going to the doctor? Are you going to spend your Friday nights going to the doctor because you suddenly can? I think a lot of the times, especially if you spend any time in the emergency room, it's people there as a last resort because they've put off all that preventative care. And so I don't think it's going to incentivize people to get as much care as they can. And we see that in other countries where that's not the case. So just that comment.
Yeah, and I can say from my time as a chaplain, currently working in emergency rooms, we'd see some of the same folks every Friday, and we'd bid them farewell on a Saturday or a Sunday, and then we'd see them again the next Friday. I mean, we called them frequent flyers because, quite frankly, these are folks who needed services, including behavioral health, including addiction treatment, and including just general preventative care that they were not able to receive. As a result, they ended up in a system that was far more costly and less effective to their well-being. Yeah.
And if I can add one other, because Sally, I think you were getting to the real heart of what reform looks like. And I'll quote Kevin Unger, who many of you know is the CEO of Poudre Valley Hospital and Medical Center of the Rockies. Years ago, in talking to him about this, his parting words were, "Rich, if you can get all the financial incentives in alignment, that would be nirvana." Improved Medicare for All realizes financial incentives are important, just like we talked about incentives to get doctors working in rural and hard to serve areas. Some of the structure around financial incentives is that hospitals would be paid on what's called a global budget. It's not unlike what we do with public education, that a high school gets a budget and the principal has a reasonable, I think, a fair amount of flexibility on how to allocate and pay for that. So there would be sort of a rolling average based on the socioeconomic demographics of a particular community a hospital is serving, and then they could use the resources the best way they can to serve that community. which disincentivizes them to do a lot of unnecessary tests. It also incentivizes them to make sure people are healthy, are getting those wellness checkups, so they're not showing up and consuming part of that global budget. So a lot of it is just common sense. Build in the financial incentives for the doctors, the patients, ourselves, and the single payer system to all behave well and be in alignment.
Okay, I need to jump in here. This is Sally. And then to go back to my question, actually it was Keith's question. I have heard of certain clinics and certain places in the world where doctors got paid more for keeping people well than treating people who are sick. And that's kind of what the second part of that question was about, is how to incentivize the medical system to keep people well would be a great step.
One more example of that, Sally, is, again, we can learn so much from just looking around the world. These are not unique questions, and other countries have dealt with them. Global budgets for hospitals, one. And the other is a phrase, if you haven't heard it, is called capitation rates, which is getting at your question. That would mean for a primary care provider, you and I and everyone would say, Joe or Fred or Sally is going to be my doctor. Sally then gets paid X amount of money monthly from the single payer system for each person that's chosen Sally as their doctor. Sally is incentivized to make sure you're as healthy as possible, because Sally gets to keep all of that money each month, whether you're healthy or sick. So that's one of the examples that's frequently used. And that doesn't necessarily work in a lot of the specialties and surgery areas, but it could very well work in a lot of other areas.
So I see two more hands raised, and I'm wondering if that's not then a good point to call it an evening, with the offer to follow up certainly more. Jim, would you like to go as give us a couple remarks?
Sure. I would just like to comment about the political feasibility of a single payer plan versus these public option plans or the incremental plans. And just to say, when Michael Bennett was running for president, I got all these emails from his campaign saying that 180 million people love their private insurance provided by their employer. Well, the pandemic has shown the weakness of that position and how tenuous that employer-provided health insurance is. So the political landscape has dramatically changed over the last 6 months, and the possibility for a single payer kind of initiative is much increased. The other thing is that what we have found, I think, is that the faster the implementation is, as in traditional Medicare, the better it is, rather than these incremental steps that take a longer period of time, because the incremental steps end up costing a lot more money, and that is a political disadvantage. So the faster we can implement it, the more cost savings we will have, and the more satisfied people will be with the benefit.
Good. Thank you, Jim. Elaine, would you like to offer some remarks?
Yes. One thing, when we were collecting signatures for Amendment 69, I often talked with people about, and this was kind of a just imagine thing. Just imagine you could pick a doctor, you could have, get a really good relationship with that doctor where I mean, you have to, it's tough changing your primary care doctor every time. I was a nurse. Every time the hospital changed policies, then you would have to get a new doctor. And so it's so much of healthcare is relationship, and being able to have a relationship with your medical provider for as long as it works is a really huge advantage. And it ultimately, if you know one another, it makes that end of life care much more simple, and have a real understanding between the doctor and the patient. And so I just think that this is what we need to do. And I couldn't help but be at the salon and invoke Eliza. When we do things like this and talk to people about universal health care, is I cannot help think of Eliza. And I know she's just sitting on our shoulders and her eyes are twinkling. And she really wouldn't believe, I think, really the progress that's been made since we were out there talking to people that had no idea what we were talking about. Now it's just part of the common discussion. So thanks, Eliza.
Oh, thanks. Okay, great. Emily, can I turn it over to you for some closing?
Sure. So I put this up earlier, so you would all be seeing it. But we just want to acknowledge the groups that put this together. So this came together through the Larimer County Healthcare Action, which is a group that all of us presenters are part of, and a lot of people in the audience are part of as well. We have a Google group, and on it we share really great emails and resources. The Colorado Foundation for Universal Healthcare is obviously a huge advocate in this fight here in Colorado. And then Democratic Socialists of America, Fort Collins, which Julie and myself and Jeff and Christy and Elaine and a bunch of people are part of. And DSA has a huge Medicare for All campaign. So those are the groups that put this on. I put in the chat, but a huge thanks also to Elaine, Jerry, and Jeff, who weren't panelists, but did a ton of the work behind the scenes to help make this event be what it is. We are working on putting together a Google folder full of resources, PDFs, presentations, slides, this whole slide deck, surveys, everything that you could want. So I couldn't get it done by today, but we will have it available. We might be able to email everyone that came to this event, but we will also have it on the DSA Fort Collins Facebook page, which will also force you to go check that out. And you can also always email us. I think most of you have our emails to, if you can't find it. So thank you, everyone.
So this is Sally, and I want to just give a big round of applause from everybody. This was a terrific presentation. Thank you all. Thank you for everybody in participating respectfully. And we will look forward to seeing everybody again in a couple of weeks.